Okay, in Module 2, we're going to look at the diagnosis of ASD and PTSD and also some of the events that would possibly trigger this particular type of disorder. And so, according to the DSM-5, one of the things to note is that media exposure does not qualify as traumatic stress. And where this was really put to the test was back in 2001 with the September 11th attacks on the World Trade Center. And when you were living through that, you saw on the TV just repeated over and over again the planes slamming into the high rise and those collapsing and everything else that was going on. And a lot of people had a real difficult time. They couldn't turn away and then later experience kind of some traumatic symptoms. But the DSM had to clarify and said if they only watched it through media and did not necessarily have this kind of secondary exposure of where it was the learning of the violence to a loved one or repeated extreme exposures, then it wouldn't classify as ASD or PTSD. But this was something that had to really be kind of refined because there were a lot of people who reacted strongly to that particular event. And as you imagine, there's a lot of disturbing video out there that individuals, if they are exposed repeatedly to it, could be traumatized by. Now, there are some things that can help prevent PTSD from developing. And of course, this is stuff that usually is before any of the trauma would occur. So there is this sense of hardiness. People who kind of roll through almost all obstacles and just are really good at landing on their feet regardless. There's a sense of commitment. So if the trauma happens in a situation where you're committed to a particular cause, it's less likely for that trauma to impact you. The amount of control that you maybe had over the situation or felt that you have over the symptoms, and then finding challenge in the face of stress. So when things are stressful, some people retreat, some people freeze, and others go right into it and face the challenge. So if you're a type that faces the challenge, it's less likely that you're going to have a risk of PTSD. Now, if you have a traumatic enough experience or exposures over a long enough time, even those who are very hardy and have some of these other characteristics could develop PTSD. And of course, this has been an object of interest for the armed forces for quite a long time because we've been in battles for well over the last couple of decades. And we have an extremely high rate of PTSD among our veterans and current active members. And when that happens, obviously, it destroys their functioning. It becomes very difficult for them, whether they're still in the armed forces or they're out in the general population back home. And so the Army's trying to figure out ways to minimize the risk of PTSD because, of course, battle is going to be one of the big areas. So that's like the armed forces. That's the traditional PTSD. And actually, there's a whole history. PTSD has been around a long time. It's not been called that. Different battles had different names for it. So there was battle fatigue. There was shell shock. There was a couple other names that are escaping me right now, but they all pretty much soldier's heart. That was another one back in the Civil War that they called it. So we've had this and the effects of trauma for a long time, but maybe not as a good way of recognizing or classifying it. So another way, a very significant trauma that we see mostly in women is the issue of sexual assault. So in women, there's a 10% lifetime rate of rape in women and a 12% lifetime rate of sexual molestation in women. And so if you think 1 in 10, and the fact that most of those 1 in 10 do show signs of PTSD, you can see why the Me Too movement and several others kind of movements to address women's rights and things couldn't come soon enough because we certainly want to reduce how many of these women are experiencing these traumas, and it is so common. So of those who do experience sexual assault, most of those are showing PTSD. So you can have that re-experiencing the horrors of the assault and reliving it over and over. Or they might experience the feeling of being numbed in reacting to others, particularly sexual partners, as you might imagine, because the two are paired. It's a similar act, obviously done with very different intents and in very different contexts, but the act itself is somehow bound. And so it can be hard for a woman to react to a sexual partner if they've experienced a rape or sexual molestation. They could avoid potentially threatening situations, and that's because they maintain that high hyperarousal that I was talking about back in Module 1, and then hypervigilance against any other possible victimization. So if it's happened once, it kind of destroys their confidence that they're safe in an environment and that they always need to be on guard, which of course can wreak havoc with your stress and anxiety levels, in addition to showing up in the form of PTSD. With sexual assault, some of the symptoms, other additional symptoms other than PTSD, depression is extremely common with a lot of sadness and crying. They may withdraw from others, and you might see sleep and appetite disturbances from that. As once again, a lot of these reactions would be totally expected, as you can imagine, with anybody who's experienced something like this. In regards to sexual behavior, a lot of times those victims have a loss of interest in sex, or they feel insecure about their sexual identity, and may experience some sexual dysfunction. Not surprisingly, also feeling negative feelings towards men, who are most often the perpetrators of any sort of sexual assaults. And then, of course, many victims also blame themselves. In our environment for many years, the sexual victim was oftentimes kind of castigated and blamed to a degree for that assault occurring from them. As you can see in the picture there, things like don't show so much skin, otherwise you're asking for it kind of attitudes. Now, once again, fortunately, that kind of assumption has changed. It has been gradual, but it is changing, and much for the better, so that people don't blame the victim, who, of course, have nothing to do with being assaulted other than being in the wrong place at the wrong time. In addition to PTSD, we see a lot of comorbidity goes along with it. Depression and anxiety, not surprising, due to the sort of symptoms that we've been talking about throughout this module. And as I mentioned before, in our mood disorders, depression often follows a lot of these other disorders, not just anxiety, but obviously with PTSD, because basically your understanding of your world, your confidence in what you know, has been pretty much destroyed by these type of violations or traumas. And so that can be a lot to overcome. Some people resort to a self-medication or a way of escaping by the use of substances. And so that they don't have to think about it, even if it is just a temporary escape, it's one where they can finally feel normal or feel good after having all of these issues. Now you can see some of the comorbid problems that they have: disturbing nightmares, whether it's reliving the event or having fear of it occurring again. You have a lot of gastrointestinal issues, so you can have stomach aches. You can also have, that pounding head from that hypervigilance creates headaches. There's feelings of grief for whatever was lost with the trauma, or if it's sexual assault and what was lost there. And then the development of relationship difficulties, because once again, that depersonalization that we talked about in Module 1 with PTSD can really come throughout here. So we already talked a little bit about the sexual assault victims and how frequently that occurs. Now we're going to talk about the overall frequency of ASD and PTSD. So we'll go ahead and look into that in Module 3. So stay tuned for that one.